Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record. Please also remember to fill out the program evaluations, and particularly the line asking for topics or speakers that you'd like to hear. Several years ago, the CME committee approved a series of Grand Rounds that highlighted services offered here at Mary Greeley that people might not know about. And to that end, our speakers today have kindly accepted our invitation. Speakers are Kathryn Albrecht and Dana Barnard. They are both licensed physical therapists and members of the Department of Rehab and Wellness here at Mary Greeley. And they have kindly accepted our invitation to update us on the two vestibules. And please join me in welcoming Kathryn Albrecht and Dana Barnard.
Thank you. Okay, can you guys hear me okay? Great. So I'm Katie, and I have been here at Mary Greeley since 2011 as a member of the outpatient team through the Department of Rehab and Wellness. And I feel really, really fortunate to be part of this team. I work with other physical therapists, speech therapists, occupational therapists, and within our PT realm, we have just multiple areas of specialization and expertise. We have aquatic therapy, we have a certified hand therapist, we have geriatrics, neurologic rehab, pretty phenomenal sports medicine programming, vestibular rehab, which obviously Dana's going to talk about later, and then my area of women's health, where I am seeing patients with all kinds of manifestations of a pelvic floor muscle dysfunction. I think that one of the dangers of being an expert in one area or being a specialist is that you can easily just focus a little too much on your one area of expertise and maybe lose sight of the big picture. And so one of the reasons why I'm really proud to be part of this department is that one of our departmental goals is just to really make sure that we never lose sight of that big picture, that we are always treating our patient as a whole person so that we can really best meet their needs. So Dana and I are talking today. We thought the best way to really give you an overview of the two vestibules, so to speak, would be to present a case study that we shared together, and it really highlights how working together can really provide a great outcome for your patients. So I was referred a patient she's a 66-year-old woman. She actually asked her family doctor for a referral to physical therapy because she was having some bothersome leakage of urine. And she had heard about Kegel exercises and was interested and asked for a referral. I'm going to talk, I should have probably flipped these things on the slide. I'm going to talk first about her symptom history. So what she told me was that her primary concern was that of urgency. She would get a very strong urge to urinate and then could not make it to the bathroom in time. Every now and then she would have some stress incontinence, leaking with coughing or sneezing. But this was happening, she said, almost exclusively if she had a really bad case of bronchitis or something. Very rarely and not enough to be bothersome to her. So she was wearing pads 24/7, changing her pads about 3 to 4 times a day. And interestingly, when I asked her more about that, she was changing her pads only 3 to 4 times a day because she was only going to the bathroom 3 to 4 times a day. And then she would oftentimes get up to go to the bathroom at night and have to change her pad then as well. Her biggest concern was leaking in the morning on the way to the bathroom. You can see on the left she has a history of Parkinson's. She had a very difficult time initiating her movement when first up in the morning, and it would take her a very long time to get that movement coordinated in order to get to the bathroom, and she would almost always leak on the way there. She didn't have any pain with urination. She didn't feel like she was having any difficulty fully emptying her bladder. No symptoms of prolapse. She was drinking mostly water all day. No soda, no coffee. So that was nice. But she was only getting up every 3 to 4 hours to go to the bathroom. So because her movement was so difficult for her, it was an ordeal to get up and go to the bathroom. She just didn't. She would just stay at her desk instead. She did say that she was having some dryness and pain with intercourse. And then she told me right before we were going to start her exam, she said, "Oh, before I lay down, I better let you know that for the last month or so, I've been really dizzy. Like every time I lay down, and then sometimes when I sit up, I get really dizzy. So maybe we could, prop this table up so I don't need to lie down." And she also offered that she has knee arthritis and has pain with prolonged sitting and stair climbing. So her medical history was significant for Parkinson's with recent falls, constipation, hypertension, obesity, and knee arthritis. Medications, she was on Sinemet, lisinopril, or actually I think it was hydrochlorothiazide, Meclizine, and when she asked for that referral for physical therapy, her family doctor said, "Oh, here's a prescription for Ditropan. Why don't you can use this too." And she had the prescription, but she hadn't filled it. She just didn't know if she wanted to take a medication or not. Social history, she's married. She was planning to retire within the next 3 to 6 months, I believe. Not a smoker, no exercise program at all, because she was terrified that she was going to fall. And she did have a history of sexual abuse as a child. So her goals were to be able to go without pads. So she wanted to eliminate this urine leakage, and she wanted an exercise program. And really, the more we talked, the more we discovered that really the reason why she came is because she's going to retire. She worked as a computer programmer. She sat all day, and she was really looking forward to being active. And she didn't want her retirement to look like what she felt like right then. So before I go any further, let me just give you some quick reminders of definitions. The International Continence Society defines overactive bladder, or OAB, as involuntary detrusor muscle contractions that occur during bladder filling. These contractions are unable to be suppressed by the patient. So that is urgency, frequency, with or without urine leakage. And then they define urge incontinence as involuntary leakage of urine that is accompanied by a very strong urge. So sometimes we use these terms interchangeably, but just for the simplicity of this case study, I'm just going to call this urge incontinence. And I will mention also that bladder dysfunction in Parkinson's disease is fairly common. It can include symptoms that relate to storage, so urgency, frequency, a lot of getting up in the middle of the night to go to the bathroom. And it can also include what we consider problems with voiding, like a weak stream or difficulty initiating stream. So there are studies that show that especially for the storage problems, 57 to 83% of Parkinson's patients have these symptoms. So it's fairly common in this population. So the first question that this patient asked me was, okay, I have this prescription for oxybutynin. Should I fill it or not? What do you think? So let's quick talk about what the evidence is for medical treatment of urge incontinence. Medical treatment includes pharmacology and neuromodulation. Medications are typically antimuscarinics or anticholinergics. There was a really great consensus paper, a huge review that I admit to not reading the full thing of, because when I printed it out, it was like 89 pages. But that's where this data comes from, and that's referenced later. So in order for one patient to have improvement in their urge incontinence, 9 patients would need to be treated. with Ditropan, 9 with Vesicare, 12 with Detrol, and 5 with vaginal estrogen. And one of the really common complaints with medications is the side effects, dry mouth and constipation in particular. So this patient was really concerned. She said, I'm already constipated, and I'm worried that if I take this medication, it's going to get even worse. So the other side of the medical treatment is neuromodulation. 2 different forms of neuromodulation. I don't know if there's any urologists here, but to my knowledge, I don't think that we offer either of these here through McFarland Clinic. But one is percutaneous peripheral afferent tibial nerve stimulation. There are 4 randomized controlled trials that look at the clinical effectiveness for this in urge incontinence. 3 women would need to be treated in order for 1 woman to report improvement, so pretty good success rate. Minimal adverse effects, but it's like I said, as far as I know, we don't offer that here, and it requires multiple treatments, and then it seems unclear right now how often you have to go back in to get, I would call it maybe a booster. And then there's also an implantable device that provides direct stimulation to S3, and that's called InterStim. About 30% of women have more than 50% improvement. This is pretty invasive, used more commonly for urgency frequency, particularly in patients with interstitial cystitis or irritative voiding symptoms. So my answer to her question, should she take this medication, was, I don't know, do you want to take the medication? And she clearly didn't want to take the medication. And so we decided that we could first maybe work on her constipation and see if we were able to improve things. And then if she decided once physical therapy was complete that she did want to try the medication, then she would do so at that time. And let me go back just for a minute and make a note. When I was telling you about her history, that constipation was not in her chart, okay? So the things like constipation, the pain with intercourse, her dizziness, her fear of exercise, her history of sexual abuse, I only knew those things because I asked. So these are not things that are going to just be offered to you, typically. Okay, so that was the medical side of things. Let's talk a little bit about behavioral treatment for urge incontinence. Exercise. So we're talking about pelvic floor muscle strengthening exercises. 148 randomized controlled trials looking at clinical effectiveness of non-medical treatment. That's huge. In order for 1 patient to report improvement, 3 need to be treated. And in fact, there are so many studies, there are actually a fair number of studies that are comparative studies looking at oxybutynin in particular and comparing use of oxybutynin and pelvic floor muscle strengthening in patients with urge incontinence. And the behavioral strategies are shown to be more effective, and so the consensus is that this should be the first line of treatment for these patients. An interesting note about pelvic floor muscle exercise, I find it that often in life we're just constantly trying to overcomplicate things, and this is true with Kegel exercises too. If you look on Google or Amazon, type in Kegel, there's 8 million devices out there that are to help you build strength in your pelvic floor. You just need to do the exercise. So there's actually no difference between pelvic floor muscle exercise alone and pelvic floor muscle exercise with the addition of vaginal weights, vaginal cones, E-stim, and biofeedback. None of those things add anything to the patient's outcome. So most of us physical therapists consider ourselves experts in movement, But the real truth is that we are actually experts in motivating people to change their behavior. That's really what we do. And so in this case, things that we could talk with our patients about to modify their behavior would be avoiding bladder irritants. These are things like smoking, caffeine, alcohol. When I have a patient who comes in and tells me that they are leaking urine and they drink a pot of coffee a day and they smoke a pack a day, I don't mind looking at them and telling them, wow, the pot of coffee and that pack of cigarettes are really contributing to this symptom that brought you here. What do you want to do about that? Luckily for me, with this patient, this case, she came in and she said, I have this problem, what can I do? She did not say, I have this problem, what can you do for me? That made my job a lot easier. So we talk about avoiding bladder irritants. We talk a lot about constipation management, mostly because it seems like everybody's constipated. But there's actually a pretty good link between constipation and especially urge incontinence. I mean, the more full you are, I suppose the more likely there is to be pressure on the bladder itself that might cause some unwanted contractions. Not to mention all the straining and stress on your pelvic floor. We talk about scheduled voiding, so going to the bathroom at regular intervals, really whether or not you have an urge. Sometimes we need to talk about strategies to empty the bladder fully, like double voiding. So somebody who feels like, oh, I sit down and I go, but then as soon as I stand up, I might dribble some more, or I feel like I need to go again 5 seconds later. We will use strategies like double voiding to help them empty more completely. And then for those who are using pads 24/7, we sometimes have to go back and talk about just basic vulvar hygiene recommendations to minimize the symptoms that they might have from the irritation of the pads. So back to our case. When I did her exam, well, first of all, when I went to get her from the waiting room, it took us a good 6 to 8 minutes to walk 200 feet back to the treatment room because she just had such a hard time initiating her movement once she stood up from that chair. She did get dizzy, even though we didn't lay all the way back on the exam table. Her vulvar appearance was pretty normal, with the exception of a pretty thin-looking vestibule, and she did have some bleeding with exam. Her pelvic floor muscles were pretty weak, 2 out of 5, which means I can feel them contracting, but I can't feel any lift or movement. She couldn't hold that squeeze for any longer than 2 seconds, and after we did 4 of them in a row, that was just about it. She was done. She needed a lot of cueing to let her muscles relax in between each contraction. She just didn't have very good awareness. So what did we do? I saw her for about 12 weeks. We'd had about 6 visits over that 12-week time period. On my watch, anybody with postmenopausal bleeding goes back to their primary care provider. It was pretty clear that this was superficial bleeding from vaginal atrophy, but not on my watch. She went back to her doctor to get that checked out and to get a prescription for vaginal estrogen. We talked about behavioral modification. So in her case, we didn't really need to talk about bladder irritants. I just congratulated her for being adequately hydrated and encouraged her to continue drinking as much water as she was. We talked about just trying Miralax for her constipation, something simple. She added in 1 cap of Miralax a day, and poof, she was fine. Scheduled voiding, that was a really big deal for her. She had been avoiding movement, avoiding getting up from her desk at work, and so we put her on a clock. Every 2 hours, she was to get up from her desk and go use the bathroom, and she actually had to set an alarm on her phone in order to make that happen. So those were the primary areas where we focused her behavioral modification. And then, of course, we talked about a pelvic floor muscle strengthening program. She was so weak that first day that we actually started with a gravity-eliminated position in order to get those muscles to fire. So I had her laying down with her knees bent and some pillows propped under her bottom to just tip her pelvis up so that gravity would help us along. That's where we started, and each time she came, we were able to progress things just a little bit further. And then, in all capital letters, she was most swiftly referred to Dana. So this is an example of, I could have very easily just, I suppose, put my blinders on and said, okay, she's got a prescription for ditropan, and I'll just give her some Kegels and get on with my next patient. But she didn't really say, I came here to be dry. In the end, she said, I came here because this is what I want my retirement to look like. I want to be free of these pads, and I want to move, and I want to feel safe. And so for a million reasons, she needed to see Dana. I think everybody should see Dana. And the greatest news of all was that after these 12 weeks, she met every single one of her goals, and then some. So it's spoiler alert for Dana here, but she was completely dry. She got rid of all of her pads. She actually, because she was dry, she was able to start an aquatic exercise program for her knee pain and her knee arthritis. She met with Dana. She got really confident in doing other exercises. She lost 30 pounds. I mean, she's like our star pupil. Just a really excellent outcome. And she never did take the oxybutynin. So I have two things that I just want to comment on before I pass it over to Dana. The first is this slide. And this is something that I keep posted at my desk that I try to remind myself of every day. It's important to me to practice evidence-based medicine, but I often have to remind myself that evidence-based medicine is not just simply reading a bunch of articles and following whatever the data says to do. Data says, give this woman some oxybutynin and Kegel exercises, and that's all she needs. So the other pieces of that picture are your clinical expertise, your opinion. I've been doing this for 16 years. I had a feeling that she needed more than that. And then the third and probably most important thing is what your patient tells you that they need. So listen for that. And last but not least, I'm going to give you my tip for how to talk to patients about really difficult subjects. So I tell all of my PT students who are with me that if you are working as a pelvic floor physical therapist and you are not having one incredibly difficult conversation a day, at least one, you're not asking the right questions. So I talk about really hard stuff every day with patients. And the way that I like to bring this up is I tell my patients, all of us walk around with an invisible umbrella that shelters us from life's happenings. And some of us have the fortune to have this big, giant, robust golf umbrella, and others walk around with a tattered, broken, ripped umbrella. And these umbrellas represent the context of our lives. What was your childhood like? What were your parents like? Do you have financial resources? Are you safe at home? Do you have a home? Those things. And then I tell them that, and I say, so how would you describe your umbrella? What's your umbrella like? And they will offer up whatever they're going to offer up, and I will sometimes then follow that with, is there anything you think I could do, to fix that umbrella? What would it take to fix that umbrella for you? And I bring this up for this particular case because I mentioned that she has a history of childhood sexual abuse. Abuse is not an interesting side note in someone's social history. It is almost always very relevant. So in the case of urinary incontinence, about 72% of patients with a history of abuse will report some symptom relating to incontinence. And that's compared to 22% of controls. that's a lot. So that is relevant to what their symptoms are. And one of the articles that I have found most interesting actually looked at the difference between women who had symptoms of overactive bladder and women who had symptoms of stress incontinence. And I'll have to skip through my slides here, but yeah, it was 18% of women who had stress incontinence reported a history of abuse. So 18, around the same as controls. And 31% of women with overactive bladder had a history of abuse. So really significant difference between the two. And I think that's interesting because, most of the time for overactive bladder, we don't really know the source. And so perhaps the overactive bladder is the chronic disease. And we certainly know that people who have a history of trauma or abuse experience chronic disease at a much higher rate. I found that interesting. So this is my one chance to stand on a soapbox. So that's my soapbox. Ask the questions. Okay, so with that, I am going to turn this over to none other than Dana.
Thanks, Katie. Good afternoon. I'm excited to be here talking about my vestibule, and many of you who have heard me talk about vestibular problems know that I'm very passionate about it, and so you might have to give me the stop sign because I tend to talk too much about it. So just as a brief reminder, that this little mighty organ that we have, which actually I wear one on my collar, does so many things, okay? So first of all, it tells us about where our head is at in relation to gravity. Most of us know that, and we know that it helps with your balance. What most of us don't remember from our training is that this vestibular system is also responsible for keeping your eyes still or your gaze stable while your head is in motion. Without having this vestibular system, your vision would be blurry, bouncy, double. It would be chaotic if you did not have that vestibular system working. It's also responsible for knowing about your angular momentum for when you turn your head quickly, driving, did you turn the corner or not? And it is also responsible for your ocular tilt reactions, which is when you turn your head to the side, one eye has to drop and the other one has to raise so that you have vision that is binocular. Otherwise, you would be seeing double vision most of the time. So it is a very small organ, but very mighty and has a big function. So in this patient case, she has a history of Parkinson's disease, which is, of course, right away is right up my alley. She has had a recent fall, which actually she is describing that she is having falls almost once a month. She's having increased dizziness, and I put in there she's over the age of 50, which actually increases the incidence of having problems with dizziness and vertigo. Another layer to this is that she is on these 4 medications, all individually could cause symptoms of dizziness. So that puts another layer on it that we have to look at. So that triangle that Katie showed earlier about how we work with these patients using evidence-based practice, we also have to use a lot of that clinical experience. So just walking out to get the patient from the waiting area, the observations that occur are big with some of my vestibular patients. How much do they use the wall? Will they even turn their head when I walk out of the waiting area? Gives me a lot of insight. So she had classic Parkinson's disease movements with small shuffling steps and flexed posture, and she was bradykinetic. She has lack of arm swing with walking. Her facial expressions are very masked, and she frequently reaches out to support herself with the wall. Now, that is atypical for someone with Parkinson's disease. They typically will not reach out and touch the wall because they have problems with that initiation and quick reaction. However, somebody with dizziness disorders will frequently reach out and touch the walls, the furniture, touch me, touch everything on the path back. Subjectively, she tells me that she's close to retirement, she doesn't have much time off, and she doesn't really want any intensive physical therapy. So that's part of the patient perspective at this point. But she wants her dizziness to be gone. She denies that she had this type of dizziness prior to her most recent fall. And she describes her dizziness as spinning, which of course, right away, is something that I try to figure out. What is their dizziness concern? Is it lightheadedness? Is it spinning? Is it floating types of descriptions? And I've heard a million different things. I wish I had a whole list of the descriptions of dizziness. She tells me that she does not have dizziness when she is rolling over. However, most people with Parkinson's disease will avoid rolling over. And so when I asked her further about that, she says, well, I guess I really don't roll over. She does report that when she bent over forward that morning to get something out of a desk drawer, that she did feel dizziness with that as well. So one of the things that I use as a subjective inventory is the Dizziness Handicap Inventory. It's a series of 25 questions that asks about dizziness symptoms. Her score was a 26% handicap, with division of 14% in the physical realm, which is a high indication for benign positional vertigo. 10% in the functional range, and 2% in the emotional range. And that emotional range gives me a good idea of the anxiety level that this patient is exhibiting. And so then we looked at visual scanning, visual tracking. Those were normal. We did a quick head thrust to look at gaze stabilization. And just within my ability to visually assess that, it looked to be within age expectations. A lot of times I will intentionally wear a jacket or a shirt that may have a full field visual stimuli like this, because it lets me know if they're having some problems with a full field stimulus. So if they tell me if they haven't said you need to take that jacket off, or many times some of them will complain about the carpeting, just like looking at this carpeting in here might make some people dizzy. That would tell me that they're having some visual symptoms. When we tested her balance on firm and foam surfaces, it looked to be within age expectations, which is one thing that I've found clinically with people with Parkinson's disease, that even when I test them with my fancy my NeuroMan with the NeuroCom Balance Master, is that patients with Parkinson's disease will be very stable. I will see very little sway. Their scores will look great for balance. That's because they're static, and they want to stay static. However, when I add in head turning, dual tasks, or obstacles, that's when I start to see the balance problems exist. Her 6-minute walk test was 865 feet. Her age norm would be about 1,300. And you would not expect to see a decrease in 6-minute walk with benign positional vertigo, but this was more of a Parkinson's disease. She did have a positive left Dix-Hallpike, and she had upbeating left torsional nystagmus with that. Her right Dix-Hallpike was negative, and her roll tests looking for horizontal canal problems were negative as well. So the initial treatment, we really focused on cannula 3 positioning maneuver for the left posterior canal, and we discussed the potential for return of benign positional vertigo, because the chances of you getting return of benign positional vertigo are greater than 50%. And there is some newly found evidence now about ways to decrease the incidence of that. This is the first time we've had anything. There have been so many studies done, and it's the first time we've had anything that shows the ability to decrease the incidence. So we followed up in 1 week to recheck for positional vertigo and to further assess her movement. And also, we went through fall precautions. So the basic tests for benign positional vertigo are the Dix-Hallpike, which is the one on the left. And one thing to remember when you're testing with the Dix-Hallpike is as you're putting the patient down in the position for Dix-Hallpike, if you're looking at the eyes during that period of time, you will see something that looks like nystagmus. But that is not what we're looking for. That is a saccadic movement that is normal. The same thing with the roll test. You don't want to look for the nystagmus until they're in the final position. Otherwise, you'll get a false positive. So some of the evidence shows that people with Parkinson's disease do have a slightly increased incidence of benign positional vertigo. And it's about a 5% increase over the normal population, which doesn't sound significant, but I think that what happens many times is that there are so many things with someone with Parkinson's disease. They will tell you they have dizziness because they feel unsteady. Their medications may make them feel unsteady. They may have orthostatic hypotension that makes them feel unsteady, and we know all of this. So sometimes we don't always consider that this could be benign positional vertigo or something else. So I think it's important to check these patients out for that if they report dizziness. So they also have an increased risk of falls, and we do know that 10 to 17% of anybody with benign positional vertigo, that the cause is a fall, unless they're under the age of 50, and then that is the most common reason that benign positional vertigo occurs. Also, there's a lot of studies now showing that demineralization of bones can increase your risk of benign positional vertigo. And with the patient with Parkinson's disease, they have less weight bearing, so therefore they're going to have some demineralization of their bones. And therefore they're at greater risk for benign positional vertigo. So when they looked at, so they noticed that there was this increase in benign positional vertigo with people with osteoporosis and osteopenia. And so then they looked at, could this be lack of serum vitamin D causing it? And they did find that people that had recurrent benign positional vertigo were lower in vitamin D for the most part. They also then did a study where they looked at giving those people with vitamin D deficiencies that had benign positional vertigo, and they found that there was a significant decrease. This was a very large, well, in my population, 892 people is a large study for for this population, that they did have a decrease in their benign positional vertigo recurrence. I have always noticed in my practice that around spring break to Easter that I get a lot more referrals for benign positional vertigo. I always related it to seasonal allergies or other types of things, but now they actually know because of that vitamin D deficiency that we do have a season of increased benign positional vertigo because of that vitamin D problem. So these days, when I see somebody with benign positional vertigo, especially if it is a recurrent one, I am asking them about vitamin D. Are they taking vitamin D? If they're not taking vitamin D, sending them back to their physician to ask about vitamin D supplementation. I realize that these days that insurance is no longer covering looking at vitamin D levels, but I think that it is important that we address this. So I didn't put the articles about this evidence because it's just very well known in the vestibular rehab area now. is that 5 to 10 years ago, we would vibrate over the mastoid process when we treated for benign positional vertigo. But now we know that that makes no difference. We also used to put people in neck collars after doing the treatment to decrease any sudden head movements. But now we know that that only leads to increased anxiety and decreased movement, which in the end can decrease their function. And we also used to tell them not to lie down flat and that they needed to sleep in a recliner. 50% of the time that helps, and 50% of the time it doesn't help. So we no longer recommend that. Now, I do have patients that have recurrent benign positional vertigo, and that we have found that it is better to have them keep their head slightly elevated with another pillow, and that decreases the incidences of that coming back again very quickly. However, I want to make sure that we take that pillow out at some point, because many of these people are very anxious about their movement, and they will keep that pillow in for the rest of their life if you let them. So, but I don't go to their house and take it out. So, we also know that cognitive behavioral therapy, getting involved with a psychologist or a counselor, is very crucial for many of these patients because they have a lot of anxiety. And that it has been shown that combining this type of therapy with vestibular rehab gives us better success. And that there is a great over-medication of patients with vestibular suppressants. Many times the patients will tell me that their dizziness is due to unsteadiness. And they've been given some Meclizine because they're reporting dizziness. Well, we do know that Meclizine increases your risk of falls, and it also makes people more lethargic, of course, and so it increases their risk of falls. Also, Meclizine decreases somebody's ability to habituate from having a vestibular problem. So I try to counsel people about what is appropriate for Meclizine, but always refer them back to their physician to talk about their dosages and what they can do about that. So the maneuvers for benign positional vertigo, the cannula 3 positioning is the most common maneuver. However, when you look at research, it's not any more effective than doing a Simon's maneuver or doing habituation exercises. However, if I were to give a patient a choice of which maneuver you do with them, they really don't want you to do any of them, but that the cannula 3 positioning maneuver is much better tolerated. It's a slower movement. It usually just takes 3 treatments on average to have complete resolution of the symptoms. The Gans maneuver, or is also called the Appiani maneuver, and the barbecue roll treatments are the most effective for the horizontal canal involvement. And anterior canal treatments, we really don't have good ways to treat this. And there's a lot of things that are still in study, like a supine deep head bend, there's a forward head bend, and there's also the hands and knees forward head bend. All of those are still in research. And I will tell you that that's probably, I work closely with Dr. Carr Frey down in Des Moines, and probably most of the canal pluggings that he does are for the anterior canal. So on the second visit, when the patient came back to see me, she had negative Dix-Hall-Pikes roll tests, but she says she feels on the verge of vertigo with testing. And so when they tell me that usually means that they need some habituation exercises. So we just started some of those. But she also told me at that visit, I didn't wear a pad all day today. So that was a big win. We discussed other strategies that the patient uses for movement success, and she already had a few under her belt for Parkinson's disease movement. We discussed the program of the LSVT BIG program, which is a specific type of exercise program for people with Parkinson's disease. And it's really a lifelong movement strategy for them. But it requires 4 days a week for an hour each session for 4 consecutive weeks to go through the program, and she really did not feel like she could commit to that. But we did use some of those strategies just to work on exercises she could do at home and strategies to get to and from the bathroom a little bit quicker, and also working on some clothing strategies. But Katie and I both felt strongly that this was a person that needed to have some follow-up on a quarterly basis so that we could keep her using those wellness strategies. So many of the times when someone with Parkinson's disease is diagnosed early on, when they are in that early phase and have the first rigidity, bradykinesia types of spells, they get medication and they're doing better with their movement. And so at that point, they're not referred to physical therapy because the medication seems to be handling it. However, I really feel strongly that this is at the point where physical therapy needs to intervene with these patients, that we need to get them on what Dr. Spencer says, sweating every day exercise program. That this is very beneficial for people with Parkinson's disease, and it needs to start early before we get to the time when they're starting to have falls. So not only for vestibular rehabilitation do I do treatments for benign positional vertigo. That's probably only about 15% to 20% of the patients I see. I also work with people with Meniere's disease, vestibular migraines, post-labyrinthitis, idiopathic dizziness, and balance deficits due to vestibular dysfunction. I also work with post-op patients that have had acoustic neuromas, canal pluggings, or have had vestibular nerve resections. So even though Katie and I work at opposite ends with different vestibules, we still have some great similarities that we kind of bounce ideas off of. When our patients come in, they have no idea that PT does these kinds of things, and they have no idea what we're going to do. So they come in with a lot of anxiety, and we do have to spend some time just kind of getting to know the patient and kind of feeling them out for how comfortable they feel with what we're going to do, and give them a lot of explanation. And they're high anxiety, and also with Katie's area, with having a high percentage of people that have had sexual abuse, that these patients benefit from a referral to a psychologist or counselor. So initiation of specialized physical therapy in these areas has really shown to be more effective than many medications that are available. In the future, there may be medications that will address these things, but for now, this is what we have, and I think it's better than taking medications. So this requires a lot of specialized knowledge, experience, and also some creativity in order for us to achieve our improvements. With treating with benign positional vertigo, many times we have to change the approach that we're using because of neck problems, because of orthopedic issues. So you have to be a little bit creative to come up with some different ways. Katie and I rely heavily on other specialists within our organizations at the state and national levels for support and to bounce ideas off of. And it also requires a lot of teamwork between primary care physicians, specialist physicians, counselors, and physical therapists. So the current status of the patient is we continue to follow her every 3 to 6 months. She has not had any recurrence of her benign positional vertigo. She's had no falls in the past 6 months. We have some fabulous programs available to us at Iowa State for people with Parkinson's disease. They have a boxing club, they have a yoga sessions, they have singing club once a week, and they also have a dancing group. And they all are fantastic. And so this patient is involved with that. She continues to go without using incontinence pads, even during exercise, which is huge. She now has gone through the LSVT Big and Loud programs and continues to do those exercises on a regular basis. And she is enjoying her retirement, which was what her goal was. So there are no problems that we cannot solve together, and very few we can solve ourselves. So it really does take a whole village. So these are our references, and we'll take questions now.
Dana, thanks for a great presentation.
Yes.
Can you tell me a little bit more about this anterior canal plug that you said they're offering? What exactly is that, and how does that help?
So what they do is they can do any of the canals, but actually they go in and they actually take a fat pad and they put it inside of the canal that is causing chronic benign positional vertigo. And that fat pad that is in there just keeps the fluid from moving within that semicircular canal, so you therefore do not have that type of vertigo anymore. What I typically have to see the patients for after they have that is that they do have some balance and some movement perception problems after that surgery. So.
Okay, so it's just a unilateral procedure, though, is that
Correct.
right? And how does that work with the other canal working properly, but the one canal now being plugged? I don't quite understand that.
Right, and so that's part of that movement perception problem that they have, is number one, they are not getting the angular momentum perceptions of movement from that one side. And so what we do is that we have to take them through habituation. Eventually the brain will learn to adapt to that, changes and the imbalance with that, but it will adapt over time. So.
And one thing I totally agree with both Katie and you, Dana, is the physical therapist's role is really valuable at helping to reduce the patient's anxiety, develop the confidence that despite their problems, they can get through this. Because we physicians don't have enough time to keep going back to them and reassuring them that, hey, you're getting better, you're developing a confidence. So I agree with those comments that the physical therapists are actually behavioral modification specialists too.
Any other questions? Well, thank you all, and please let us know if you have any questions. We would be more than glad to answer them.